Hello, everyone, and welcome to a neurology question. Let's dive right into it. I'll read the full question first and then take a short pause so you can think about your answer. A 24-year-old woman comes to the physician with her husband for intermittent dizziness, weakness, and unsteady gait for the last several weeks. She has also had visual loss and pain in the right eye that worsens with eye movement for the past 3 days. A year ago, the patient had tingling and numbness of her right hand accompanied by unsteadiness, which improved spontaneously after 5 to 6 days. She has no other medical problems, no medications, and no significant social or family history. Her vital signs are all normal. On neurologic exam, her right eye has diminished visual acuity and an afferent pupillary defect. She also has a right arm intention tremor, and both lower extremities show spastic paresis, hyperreflexia, and a positive Babinski sign. Which of the following is the most appropriate test to confirm the diagnosis in this patient? A. CT scan of the head. B. Electromyography and nerve conduction studies. C. Lumbar puncture. D. MRI of the brain and spine. E. Visual evoked potentials. Okay, take a moment, pause the video if you'd like, and think about what the best answer might be. If you guessed D, MRI of the brain and spine, you're correct. The typical age of onset is between 15 and 50 years old, usually a young adult. One of the hallmark signs is optic neuritis. That's painful vision loss, often in one eye, with an afferent pupillary defect. Then there's the Lermite sign. That's an electric shock-like sensation that runs down the spine when the neck is flexed. It's a sign of cervical spinal cord involvement. Another classic finding is internuclear ophthalmoplegia, or INO for short. This happens due to a lesion in the medial longitudinal fasciculus and causes impaired horizontal eye movements with nystagmus. Patients can also experience Uchthoff phenomenon. That's worsening of symptoms with heat, like after a hot shower or exercise. Sensory symptoms are really common: numbness, tingling, and paresthesias. You can also see motor symptoms like paraparesis and spasticity, especially in the lower limbs. And don't forget bowel or bladder dysfunction, things like urgency, retention, or incontinence. Now, in terms of the disease pattern, MS can show up in several different ways. The most common form is relapsing remitting, where patients have flare-ups followed by periods of recovery. There's also primary progressive MS, where symptoms steadily worsen from the start without distinct relapses. Some patients go from relapsing remitting to secondary progressive, where the disease starts progressing more steadily over time. And finally, there's progressive relapsing, which is less common. Patients have a steady decline, but also experience acute relapses. Okay, now let's talk about how we diagnose MS. The gold standard is MRI, especially T2-weighted imaging. We're looking for lesions that are disseminated in time and space. That means multiple lesions in different locations, like the paraventricular area, juxtacortical, infratentorial regions, or the spinal cord. And evidence that these lesions appeared at different points in time. In addition, a lumbar puncture can help support the diagnosis. The key finding here is oligoclonal IgG bands in the cerebrospinal fluid. When it comes to diagnosing multiple sclerosis, MRI is the most important test. It's way more sensitive and specific than a CT scan, especially for picking up lesions in the posterior fossa and spinal cord, areas commonly affected in MS. Now, what about other tests? Evoked potentials like visual or somatosensory can help detect silent lesions, but they're not first line. EMG and nerve conduction studies are more useful for peripheral nerve or muscle disorders, not so much for MS. And lumbar puncture? It's not required in typical cases. It's mostly used if the diagnosis is unclear. If done, you might see oligoclonal bands or an elevated IgG index, but opening pressure is usually normal. Bottom line, MRI of the brain and spine is the best test to confirm MS.